Hi everyone, this is Amr Asker, the founder of Asker Odontics. I'm back again with new episodes. In this episode, we will discuss cases from A to Z, how to plan, and what's happened during the treatment plan. The first case we will discuss today that have spacing in the upper dentition and lower incisor crowding. The patient came to the clinic with upper incisor spacing and lower incisor crowding. In the frontal view, we can see deep bite in the anterior segment, and also we can see the 2 mm midline diastema. And in the right and left views, we can see class 1 occlusion in the back and almost class 1 relation in molars and premolars and canines, and the same in the left side. From the occlusal view, we can see anterior spaces that localized in the midline and lower crowding that's distributed in the 6 incisors. In contrast photo, we should focus on the frenum, and in this patient, she has thick labial frenum between 2 central incisors, and that indicates removal during orthodontic therapy to prevent relapse and to prevent compression after closure of the space. And the lower incisor crowding, and you can focus here on the incisal edges and on the gingival line of lower incisors. And during treatment, you can see the remodeling of the gingival tissues during leveling and alignment. In the profile photo, there is a slight increase in the overjet. It's almost about 4 mm overjet, and it appears here that the lower incisors like 4 mm overjet. In the treatment plan, we need to close upper spaces with moderate anchorage, and also we need to align the lower incisors. And the guide is the lower central incisors, so we can align the lower laterals beside the lower central incisor without affecting the overjet, and to close this localized midline diastema. The big issue in these type of cases is the angulation. If you didn't move the teeth accurately, pudgy movement, in some cases you can find the black triangles between 2 central incisors, and it will affect the patient aesthetics. So here we should move the upper central incisor, crown and root, almost pudgy movement, and the same for the laterals and canines, and for the other side the same, to avoid any black triangles. Also, this panoramic x-ray, we can focus here in the deep fissure or cleft between 2 central incisors that indicate thick labial frenum is penetrating between 2 palatal or 2 maxillary bones. In cephalometric analysis, you can focus on the overjet, that we will utilize this overjet in upper incisors 1 mm retraction, and the SNA, SNP angles looks normal, skeletal bone looks normal, and the upper central incisor looks about 104 degrees, and lower central incisor looks about 102 degrees. The vertical angulation between SN plane and mandibular plane is almost normal, 32 degrees. And we shouldn't affect these angles, which is normal. So I started with the upper arch. I reversed the brackets to reverse the teeth angulation to achieve more bodily movement between right and left sides. So I flipped brackets horizontally. So I put the upper central incisor on the right side, put it on the left side, and the same for the laterals. That will achieve negative angulation that will close bodily movement more during closure. The best time to remove thick labial frenum is after leveling and the alignment and before complete closure. So after reaching rectangular arch wire, it's the best time to remove thick labial frenum. So here I remove thick labial frenum with electrocautery. Deep removal is necessarily to remove the soft tissue inside the bone, and in the same day you should put the stainless steel rectangular wire and the power chain from first molar to first molar. Don't forget to remove the thick labial frenum 1 mm palatally and put the power chain on the same day. And here there is one hole between the chain because the gap was, the power chain was stretched between two central incisors. So I left one hole inside two centrals, and after 1 month I removed this hole and connecting the power chain completely. I started the lower arch. I started with the wire 12 in the lower arch to align the teeth. The gaining space method for the lower arch is by teeth proclination and to change the arch form from V shape to U shape. So here I started with 12 arch wire, and I expected that the lateral incisor will align beside the two central incisors in the lower arch. And because the patient has deep bite, I need to raise the bite. And I prefer to raise the bite here on the palatal cusp of the first molars bilaterally. In some cases of deep bite, if you have decreased overjet like class 2 Dev 2 cases, you can raise the bite palatally beside the upper incisors. But in this case, because I have a little bit larger overjet, so I raise the bite posteriorly on the palatal cusp of first molars. And after 1 month, I changed the power chain in the upper till complete closure. I changed the lower wire to the next wire 14, 16, 18, 16 by 22, and then finalized the case by 17 by 25. Here is the occlusion after space closure, and I did fixation by ligature wire figure 8 in the upper arch to prevent any spaces to reopen after stopping the power chain. And this is the case after complete closure of upper spaces. And in that time I removed the Fuji bite raising because to allow a little bit more adaptation and more interdigitation between first molar in the upper arch and in the lower arch. And after occlusal settling, I removed the braces, and don't forget to place upper fixed retainer and lower fixed retainer. The deep bite almost corrected, and this is the pre-operative photo, and this is the post-operative photo after finishing the case. And the overjet almost corrected. Here is like a little bit 3 to 4 millimeter overjet, and after correcting the overjet, it now looks 2 millimeter overjet. Don't forget to put fixed retainer in the upper arch and fixed retainer in the lower arch, because the spaces and lower incisor crowding has higher relapse rate. And this is the patient smile before and after. And this is the profile without huge change in the profile before and after. And this is the smiling photo for the patient. Don't forget to subscribe to our channel and wait more cases videos. Thank you.